Hello, everybody. My name is Enrique Grande. I'm the head of the Medical Oncology Department at the MD Anderson Cancer Center in Madrid, Spain. This is a franchise of the Houston Hospital, the European franchise of the Houston Hospital. And I am delighted to be here with all of you to share with you my thoughts about the neuroendocrine tumors. These are my disclosures. And I want to try to address these four questions. The first question is, how has clinical practice been changed by trials in the last 10 years? And well, this is a very complex question because we had many good news for patients with neuroendocrine tumors that are coming from the research that we did in the last not only 10 years, but 2 decades or 3 decades in the field. And let me briefly summarize what are the main outcomes, the main milestones that we have in the history of neuroendocrine tumors. The first 3 ones are coming from the older ages, are coming in let's say, in black and white, because the neuroendocrine tumors field, the research in neuroendocrine tumors fields began in 1907, when Siegfried Oberndorfer described for the first time the neuroendocrine features, cells composing a tumor, and what for the first time it was called the term carcinoid, to call these different solid tumors here. It was in 1907. 70 years after, Roger Guillemin discovered for the first time the somatostatin, and the receptor of somatostatin is key molecular driver or the key biological factor that is conditioning the development, is conditioning the symptoms, the release of hormones that are traditionally linked to these tumors. So first, the histology, the shape of the curve, the shape of the cells that are composing these tumors. Second, the biology, the hormones related, and the pathway, the receptor to these hormones involved in the development of these tumors are important here. And it was in 1982 where the first randomized, prospective and randomized trial was developed and published in the field of pancreatic neuroendocrine tumors, in which, a chemotherapy like streptozotocin was combined with 5-fluorouracil, and it was better than streptozotocin alone here. So this is what we call the older ages, in black and white, as you can see here. The first trial that was a modern trial was the PROMIT trial led by our colleague and friend Dr Enrique Grande. For the first time, a somatostatin analog like octreotide demonstrated to control, to delay the tumor growth. And that was important because until that time, somatostatin analogs were only given to patients because of the properties that they have to control the symptoms, to control the release of hormones that some of these tumors may have, functional tumors. So for the first time, it was demonstrated that somatostatin analogs were not only relieving for the symptoms of the patients, but at the same time, it was helping that the tumor growth was controlled for some time here. That was the first modern trial, and you can say, okay, but Enrique, the question that we asked you was, what does it happen in the last 10 years? And in the last 10 years, it started in 2011, where Eric Raymond, for the first time, demonstrated that a targeted agent, an anti-angiogenic agent, a tyrosine kinase inhibitor, blocking the development of blood vessels, this is what we call the angiogenesis, demonstrated to delay, to postpone the tumor growth of patients with pancreatic neuroendocrine tumors with grade 1 and 2 differentiated. That was the first phase 3 trial in the modern era with a targeted inhibitor. It was just immediately followed by 2 phase 3 trials with everolimus. Everolimus is an oral mTOR inhibitor that demonstrated in the RADIANT 3 and in the RADIANT 2 trials that was able to delay, to postpone the time the tumors are needed to grow up again. In the RADIANT 3, everolimus demonstrated to delay this progression-free survival, the time that the tumor needs to grow up again in pancreatic neuroendocrine tumors, G1 and G2 grade of differentiation. In the RADIANT-4 trial, everolimus demonstrated to be superior to placebo in delaying the time of tumor growth in patients with gastrointestinal neuroendocrine tumors and also lung neuroendocrine tumors. So we can say that everolimus, targeting the mTOR, which is a protein inside the tumor cells that is controlling two things. It is controlling the metabolism of the tumor cell, and at the same time, this is also controlling the growth, the proliferation of these cells at the same time. So mTOR inhibitors, everolimus in particular, is one of the key targeted agents that we have in this field. And these two trials, RADIANT-3 and RADIANT-4, were released in 2011 and 2016. The next trial that changed our practice, and one of the most relevant phase 3 trials that we have so far in the field of neuroendocrine tumors, are coming from the data released by Martin Kaplan, the clarinet trial, in which, a second somatostatin analog, lanreotide LAR, was able to, once again, to delay, to postpone the tumor growth in patients with gastroenteropancreatic G1 and G2 tumors with a Ki67 index less than 10%. Once again, we are adding option. We are adding systemic opportunities to treat our patients with pancreatic and non-pancreatic neuroendocrine tumors with a G1 or G2 grade of differentiation. The next dramatic change, or the next trial that changed the history, that changed the clinical practice, was coming from data released by Jonathan Strosberg in the NETTER-1 trial. For the first time, we use what we call the teragnostic. Teragnostic means that we can target the somatostatin receptor by two ways. First, trying to make a diagnosis. So somatostatin receptors are mostly focused on cells from neuroendocrine tumors. So we can link somatostatin, so how it is binding to the receptor somatostatin, but together with an atom with radioactivity. Very low radioactivity for the diagnosis, but very high radioactivity potency in terms of treatment. This is how we call the gallium PET scan to really identify cells from neuroendocrine tumors features, and lutetium, in which the potency, the radioactivity that this atom has is contributing to the break, to completely destroy the cells that are expressing on the membrane the somatostatin receptor. This is what we call teragnosis, coming from therapy and diagnosis of these patients. Lutetium dotatate is contributing to delay the tumor growth of patients with midgut and other GI neuroendocrine tumors with a grade 1 or grade 2 histology differentiation. In addition to that, the results, not only from the NETTER-1, but from the retrospective series in daily practice that we have, are contributing to the final labeling for lutetium dotatate, including not only patients with GI, G1 and G2 tumors, but also pancreatic neuroendocrine tumors. And lastly, the last systemic treatment, this is the trial, and these are the results of the NETTER-1 trial. The last trial that we have, the TELESTAR trial, was the last approved medicine, approved agent in the field of neuroendocrine tumors, which is telotristat, which is inhibiting the release of serotonin. And serotonin is the hormone that is contributing to the carcinoid syndrome. You know that carcinoid syndrome is dramatically impacting to the quality of life of many patients, around 30% of the patients with neuroendocrine tumors. This is what we call the functional neuroendocrine tumors. And you know that these patients, unfortunately, in addition to the tumor growth and symptoms related to this tumor growth, are also correlated with a poor, very poor and deteriorated quality of life because of the symptoms associated to this syndrome. These symptoms are including for diarrhea, skin rash, flushing, and some of depression related to these symptoms because of the anxiety that these symptoms may induce in the patient. Telotristat is contributing to diminish the diarrhea related to this syndrome, and it was this TELSTAR trial with telotristat, the first trial in which, we were not only looking for tumor growth control, but looking for quality of life patient improvement. So I think we have a broad range of agents that were coming in the last 10 years to treat our patients. We have 2 somatostatin analogs approved in this field, octreotide, lanreotide. We have 2 targeted agents approved in this field, sunitinib, everolimus. We have the teragnosis coming from lutetium dotatate, nuclear medicine agent that is hitting the receptor of somatostatin analogs with an atom charged with radioactivity. And we have at the end the telotristat inhibiting and controlling the symptoms related or linked to the carcinoid syndrome. These are in my opinion, the most important advances in the systemic treatment of patients in daily practice. The second question I was asked for was about which are the trials that really matters or potentially practice-changing trials that are currently open and we are offering routinely to our patients in daily practice. Which are the main research, the main investigation, the main clinical trials that may have a potential impact in daily practice in the next years? Well, of course, this is impossible to cover all the clinical trials that are up and running in the field of neuroendocrine tumors, and this is a very good news because, in the past, unfortunately, neuroendocrine tumors were a little bit, I wouldn't say abandoned, but at least not taken as a priority for the pharma companies developing new drugs. So in the way that we have many more trials in this field, this is something very good for patients that hopefully sooner or later these trials will be translated in data that are contributing to the treatment of our patients in daily practice. Let me bring up here what I am considering the most important and relevant clinical trials in the field of neuroendocrine tumors. The first one is the SECTOR trial. The SECTOR trial is a very elegant trial in terms of the design, in which patients with pancreatic neuroendocrine tumors, G1 and G2, are randomized 1-to-1 to receive everolimus of streptozotocin. So it means targeted agents, an mTOR inhibitor like everolimus, versus what the chemotherapy, traditional chemotherapy, can offer to our patients. Initially, this trial was designed to compare the sequence of mTOR and when the patient is progressing, when the tumor is growing up again, to switch to chemotherapy, or the other sequence around, chemotherapy first, and when the tumor is growing up again, to switch into a second-line treatment with everolimus. Unfortunately, because of the delay in the recruitment, unfortunately, we needed to change the primary endpoint of the trial, and it was at the end a head-to-head comparison of what we can expect in terms of activity of novel targeted agents like everolimus versus head-to-head to streptozotocin, the chemotherapy. Results are still pending, and hopefully in just 2 weeks from now, from the recording, at ESMO 2022, this data will be released, and we will see if chemotherapy is better than targeted agents or targeted agents are better than chemotherapy in the field of pancreatic neuroendocrine tumors. And when I say better, means more responses and more chances to delay the tumor growth progression. The second trial that may change and may contribute to add another drug to the field of neuroendocrine tumors is the CABINET trial. in which cabozantinib, which is an tyrosine kinase inhibitor targeting and controlling the angiogenesis, and other, they have off-side effects like inhibiting the MET inhibitor, for instance, in which it is involved in the clinical development in those patients that are developing resistance to other tyrosine kinase inhibitor or other targeted agents in the field of neuroendocrine tumors. Patients with gastroenteropancreatic tumors, GI and pancreatic neuroendocrine tumors, G1 and G2, will be randomized to receive cabozantinib or placebo, and these patients may have been treated not only with somatostatin analogs but also with mTOR inhibitors before. So hopefully cabozantinib could be added to the armamentarium that we have shortly to treat patients with gastroenteropancreatic tumors. Another phase 3 trial that may have impact in the clinical practice we will have shortly is the COMPETE trial, in which lutein edotriotide will be compared against everolimus in patients with well-differentiated neuroendocrine tumors of non-functional gastroenteropancreatic origin, or both functional and non-functional pancreatic origin. This is the first trial that will face prospectively if radioligand is better than everolimus, the mTOR inhibitor, in this field. There are two other drugs or two other trials that is looking for a patient population a little bit better, a little bit different than others, in which patients with more aggressive disease, patients with G2 and G3 neuroendocrine tumors, patients with a Ki67 index higher than 10% but lower than 55%, will be randomized to receive lutein edotriotide in the COMPOSE trial, and here the control arm is chemotherapy or everolimus, capecitabine temozolomide or Folfox, or everolimus as a comparator arm, depending on the investigator choice. This is the COMPOSE trial design. Same patient population or very similar patient population was also considering in the NETTER-2 trial. Once again, the radioligand, at this time lutein dotatate, will be compared with high doses octreotide LAR. This is the main difference in between the COMPOSE and the NETTER-2 trial, the comparator arm. In the COMPOSE, it was chemotherapy or everolimus, targeted agent. In the NETTER-2 trial, it will be the high doses octreotide LAR, the comparator arm. Well, I think this trial will bring us evidence about the use of radioligands in patients with more aggressive features, patients with grade 2 or grade 3 neuroendocrine tumors with a Ki67 index in between 10% and 55%. And finally, the phase 3 trial that may change and may add a new treatment on the field of neuroendocrine tumors is the SORENTO trial. This is a new somatostatin analogs, which is including a subcutaneous depot. This is not an intramuscular, or this is not a deep subcutaneous compound like octreotide or lanreotide. This is much easy. This is supposed to be much easy for the patient to get administered. However, this is given every 2 weeks. Let's see if this new compound is more active, more potent, and the most important thing, better tolerated, and helps the self-autonomy of the patient to be treated with this kind of agent. So let's see. In my opinion, these are the trials that may change or may impact in a short term in the armamentarium that we have to treat our patients in daily practice. The third question I was asked for to respond is about if what is missing in neuroendocrine neoplasms research to have the biggest impact on patient care and outcomes. We have a lot of challenges here. I'm bringing here the most used guidelines together with the INETS guideline, which is the ESMO guidelines, the guidelines from the European Society of Medical Oncology. And if we take a rapid look to the guidelines, we can easily see that we have a tremendous heterogeneity of clinical situations and subsequent lines of treatment that we can offer to our patients. This is easy when you see this graph, to think that probably there is a lack of robust recommendation behind each square that you can see here. We need more evidence, not only in the first line setting, but in the second line setting, in the third line setting. We need to know which is the best sequencing strategy for each particular subgroup of patients. The clinical heterogeneity, the differential nuclear expression in the PET gallium or in the scintigraphy, in the octreoscan of the patients, the functionality, the differences in functionality of the patients, if the patient have hormone release or they don't have hormone release, how much they are uptaking in the scintigraphy or in the PET gallium. What are the differences in the histology of the patients are also conditioning the systemic treatments and the subsequent lines of treatment of the patient. So when you see here, you can realize how many challenges we have in daily practice to face these patients in the clinic. We also don't have good and reliable biomarkers to offer to our patients. What is a biomarker? A biomarker means tools, analytics, markers that we can find in the clinic or we can find in the blood of the patients that are helping us to identify in front of which patient we are. That these biomarkers are helping us to know in advance if the patient is going to respond or not to the systemic treatment that we can offer. In the past, we were considering that tumors, we were made all of these, like all of the cells were similar, were equals one to the others. So if we have a magic treatment targeting the almonds, you can hit and you can defeat the tumors at all. Unfortunately, however, the tumors are made of different clones of cells, and each clones of cells are driven because of different molecular alterations. And we don't have targets, we don't have drugs targeting all of these different molecular alterations. What does it mean, a biomarker? A biomarker means that this is a tool that we have to know in front of which patient we are from the molecular perspective. This is a tool that is helping in the clinic to identify if we are facing a patient made of almonds or made of pistache or made of grapes or whatever the tumor may contain. This is our responsibility, our role as a physician treating patients with neuroendocrine tumors, to identify in front of which patient we are from the molecular perspective and adapt the systemic options, the systemic treatments that we have to the patient we have in front of. This heterogeneity of the tumors that we have, this is also companioned with patient heterogeneity, which means that a patient with a pancreatic neuroendocrine tumors from the molecular perspective may be completely different from another patient with a pancreatic neuroendocrine tumors, because the molecular driver can be different, and this is explaining the differences in the responding, how many patients are responding to one or another medication. What is the problem that we have in daily clinic? Well, we need to identify in front of which patient we are from the molecular perspective. Some of the patients will respond great to mTOR inhibitors, but some others, mTOR inhibitors will do nothing except offering for toxicity. This is what we should avoid in the clinic. We need to identify, we need to know who the patient we have in front of the chair are. Because if we know that the patient is going to respond to an mTOR inhibitor, definitely we will give them an mTOR inhibitor. But if the mTOR inhibitor is not going to work at all, why don't we try a radioligand? Why don't we try a somatostatin analog? Why don't we try an anti-angiogenic agent or any other clinical trial that may help and may fit in the patient profile that I have in front of? When I say biomarker, I mean to know in front of which patient we are from the molecular perspective, but also from the toxicity that I can expect from the drugs that I have in the clinic. And this is important to bear in mind. What I am talking about? I'm talking about that these two patients that you can see here, the histology of these two patients that I can see here, are completely different. In brown, you can see that this patient, the patient 1, is overexpressing, has a lot of receptor related to immunotherapy. But the patient 2 has no expression of these receptors. This is easy to explain, that probably patient 1 will be very likely to respond to immunotherapy because these factors are related to the response of immunotherapy. However, patient 2 is not expressing this receptor related to immunotherapy, so the chances to respond will be much less. This is translated into clinic? Well, I think it is. This is the typical overall survival graph, in which this is like a Gauss curve, in which you have patients that are not responding at all in the let's say the left part of the curve, and you have long-lasting responders, those tumors in which the treatment is extremely active, the response is good and durable in time. This is what it is reflected in the graph. This is what we all want, to identify those patients that are benefiting more from the drug. But this is important to bear in mind in the clinic. However, it is even more important, don't harm the patients. If you cannot cure, at least don't harm the patient. This is not only important to identify who will be the patient responding better to the drug, but it is even more important to know in which patient I am not gonna do any benefit, because the only thing that I will induce to do those patients will be toxicity, and we need to avoid to give toxicity in absence of efficacy. So we need to identify the streams that we call biomarkers in daily practice. Biomarkers means that we need to know in front of which tumor we are, in front of what are the molecular drivers that are conditioning the growth of the tumor. But unfortunately, we cannot really know which is the leader, because the tumor is extremely heterogeneous, and some clones of cells, some molecular alterations can be together in one tumor. So this is the reality. However, this is what we see, how we see the tumors, because of the biomarkers that we can capture from the tumor. And we need to try to make the full pictures from one particular side, because one biomarker means I am taking a look at the tumors from one perspective, and we need to try to realize the reality from this perspective that we have. We have a lot of biomarkers that are in research so far. Unfortunately, when you have a lot of biomarkers in research, this is because you don't have a very good and reliable one to use it in daily practice. Only Ki67 index, only the grade of differentiation in the histology of the tumors, only how much the tumors are uptaking the scintigraphy or uptaking in the gallium PET scan are helping us to select one or another systemic treatment options. But take a look at how many different biomarkers are in research so far, impacting in the liquid biopsy, so it means in the blood of the patient, what is circulating in the blood of the patient. The blood is helping to identify in front of which patient we are. The tissue remains the main source for biomarkers that we have so far. And of course, nuclear medicine technologies are also helping us to identify in front of which patient we are from the molecular perspective and from the functional perspective. What is going to happen in the future? Shall we be able to identify a good and reliable biomarker to use it in the clinic? We are still a little bit far from this day. And the fourth and last question that I was asked for is, how important is it to have meaningful patient input in clinical trial design? And I am delighted to try to respond this question, because I think it is extremely important. And we need patients to be involved in the design of the clinical trials. Neuroendocrine tumors are extremely heterogeneous, and extremely heterogeneous because of the low incidence that they have, because of the different locations that the primary tumor may have pancreas, gastrointestinal tract, lung, even we have unknown primary origin tumors. The histology can be different. The grade of differentiation, nothing to do a grade 1 with a grade 2 or a grade 3. Nothing to do a neuroendocrine tumor with grade 3 differentiation from a neuroendocrine carcinomas. We have seen that treatments, systemic treatments that we have are very different, ranging from the indolent somatostatin analogs to the more aggressive chemotherapies that we can use it in daily practice. We know that from the genetic perspective, the molecular alterations that we can expect in patients with neuroendocrine tumors are very different if they are coming from the pancreas, from the gastrointestinal tract, or from others. Multidisciplinary team is extremely important. Nothing to do the options that a patient may have in a site, in a center, which they have a very good and multidisciplinary team involved in the management of the patients, than unfortunately centers that still today, unfortunately they don't have so many specialties that needed to be involved in the treatment and in the management of these patients. Of course, access, because of the cost of the new medications or the new technologies that we have, like PET gallium, are impacting in the access to the best care for patients with neuroendocrine tumors, diagnosis of delay, functional tumors versus non-functional tumors impacting in the clinic. And sometimes these aspects, symptoms induced by the tumor, while different treatments are not well contemplated by the patient input when designing clinical trials. Why is that? It's because the quality of life of patients with neuroendocrine tumors may be dramatically affected. Diarrhea is really impacting the quality of life of the patient, and this is very easy to understand. If you have a patient in front of you with diarrhea, and I would say in some cases severe diarrhea, of course, grade 3, grade 4 diarrhea, which means that the patient has more than 8 stools per day. 8 stools per day is a lot. But this is not just a matter of those dramatic cases with the more severe diarrhea. This is just a matter of patients with 2 or 3 diarrheas per day. 2 or 3, we can say, this is acceptable. And this is true, this is acceptable. And from the physician perspective, from the investigator perspective, a grade 1 diarrhea, 3 stools per day, it is reasonable and it is acceptable. However, think about the quality of life. Think about the self-confidence of the patient with grade 1 diarrhea. If you have 3 stools per day, the stools are not knocking on the door. When you want to let them come in, this is perfect, but when you don't, just simply stop the door and you don't open. This is not the case. If you are a patient with a carcinoid syndrome, if you are a patient suffering from this diarrhea, only grade 1, 2, 3 stools per day, not more than that. Okay, do you feel confident by using the bus? Do you think that in the commute in the bus, you will not be needed for a toilet? Do you think in your self-confidence, would you be confident that, you will be calmed down with this, without the anxiety to get a toilet? Or, I am not using the public transportation, I am using my own car. Are you free of a traffic jam? Do you know if you are in a traffic jam, do you have easy access to a toilet? Do you know when you will find a traffic jam? Will you be able to get this toilet? I think this is important to realize about that and to think about that. Do you think investigators are considering how tough, how hard can be this grade 1 diarrhea, which is almost indolent for me? When we are designing this trial, do you think we should adapt the goals, the endpoints of our trials to this particular scenario, to the quality of life of our patients? Or, okay, I have a chauffeur that is driving me, so I don't care about that. You are very important, so you have meetings. So do you think a patient with a neuroendocrine tumor, only with grade 1 diarrhea, do you think he feels confident in a meeting? I don't know, 1 hour meeting? Do you think that in a well, let's say a hard meeting, exciting meeting, everybody discussing about one clinical case with passion, don't you think that only grade 1 diarrhea can affect not only to your quality of life, but to the daily life in terms of job, in terms of work that you have? Because probably one of these guys that you can see here in the picture with the neuroendocrine tumors, well, probably during the meeting should stand up, go to the toilet, and come back again. Do you think this is good for the job of the patient? Do you think this is good for the self-confidence of the patient? Do you think we are really considering diarrhea as a one key goal, one key objective in the clinical trials? Only one of all the trials reported in the phase 3 trials reported in the last decade were considering diarrhea as a primary endpoint. And diarrhea is really impacting. Do you think a patient with a grade 1 diarrhea because of the carcinoid syndrome may take a plane? Because of the self-confidence, would I need a toilet, and the toilet will be available when I want to use it in a plane? Well, probably not. Another even more stupid thing, because the researchers are not really considering this as a severe deterioration in the quality of life. Your sweetie hands. Well, most of the people with neuroendocrine tumors, with functional syndrome, with carcinoid syndrome, they have sweetie hands. And socially, this is very, very disgusting to shake hands with others. Do you think that in any phase 3 trials, at least in my experience, do you think that, well, we discuss 1 minute about how important it is to improve the sweetie hands of our patient? Do you think how much these sweetie hands can affect the social life of the patient? And don't forget that around 73% of the patients with hormone release syndromes, they have around 40-50% of the patients, but 73% of the patients will be missing the control of the symptoms related to carcinoid syndromes in the first 1 year. So somatostatin analogs are very good to have. Somatostatin analogs are the backbone treatment strategy, systemic treatment strategy to the treatment of patients with functional tumors. And this is great, very good drugs. However, take a look at the drop in the percentage of patients with control of the symptoms of the carcinoid syndrome. Somatostatin analogs are great, but they are not curing, and they are not preserving from the appearance or the recovery of the syndromes, of the symptoms related to the carcinoid syndrome. So we need better drugs to control the quality of life, to help the patient to improve the quality of life. Once again, this diarrhea, these sweaty hands, this flushing that is induced by carcinoid syndrome, take a look at how much it is impacting in the depression feeling, fatigue, tiredness, anxiety, pain impact, sleep disturbance. And this is directly related with the get it more and more pure, the social role and the physical function. This is why it is important to have the patient input when designing clinical trials, because of course it is important to live longer, but at the same time it is important to live better. And sometimes we are forgetting about this living better. This is why it is important to have the patient input. This graph, it is reflecting the subsequent lines of treatment that we can offer to our patients. And take a look at how many different combinations we may have just with these 4 agents or 4 different mechanisms of action that we can offer to our patients. Do you think there is one single best strategy for all patients with neuroendocrine tumors? Not at all. Depending on the primary tumor location, depending on the histology grade of differentiation, depending on the Ki67 index, depending on the where the patient is treated, in a multidisciplinary environment or only one single doctor treating the patient, depending on the access to drugs, access to different medication, depending on the access to clinical trials. We may have hundreds, thousands, I would say, of different subsequent lines of treatment to offer. Which is the first one? There is no first or preferred subsequent lines of treatment choice. The best one for each patient that you have in front of you is the discussion into the multidisciplinary team and discussing which is the best treatment at each time point of the disease, considering that we all want the patient to live longer, but we all want the patient to live better. And this living better, this improvement in the quality of life should be one of the key clinical goals that we may achieve. And unfortunately, sometimes this is not very well captured, very well considered when designing clinical trials, when selecting the main objectives of a clinical trial. Thank you so much to all of you for your attention, and I really hope these questions and responses help you in the better understanding of the disease. Thank you.